Dear colleagues, good morning. Welcome to this symposium about complex acne and inflammatory skin diseases. We are very happy to have very wonderful speakers, and I hope that this session will be so helpful for our clinical daily basis. With me is Dr. Monica Fida, and we will have this session, so please be so interactive and participate with us.
Thank you. Thank you, everybody, for being here. So I think that we have to start the session. And the first speaker will be Dr. Arzi Ofir with the theme, A New Area of Follicular Dermatologic Diseases, Real-World Evidence of Fractional Radiofrequency in Acne vulgaris to hidradenitis suppurativa. Thank you, Dr. Ofir.
So good morning, everyone, and thank you for waking up and finding the room, because I went up and down and I was running. Unfortunately, I'm going to give the talk, and today I have 7 in a row, outside and inside. I hope I will manage, but I think I brought kind of a new thing. I'll start by saying, how many of you are dermatologists? Raise your hand. All right. So whenever you talk about dermatology, and we talk about the different, I would say, revolutions in dermatology, I will not get, in the sake of time, into details. However, one of the advancement, the revolution, is the technological revolution. So if 100, 150 years ago, we actually prescribed only creams, now we have biologics, we have probably the last 50 years, and it's going to be more and more, is the technological revolution. And I'm not going to convince you. In the hospital, I am the head of a department of dermatology, and we offer technological solutions for many, 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 many skin diseases. I have a different, maybe next IMCAS I'm going to tell them, we do it for different genodermatosis and for different inflammatory reaction. But here I'm going to focus about acne and another thing. I'll start with acne. So whenever you talk about acne, there have been so many publications supporting the use of different energy-based devices, light. And when we talk about light, we talk about different photobiomodulation and IPL. We know different lasers. Okay, different lasers were proven in different studies to ameliorate acne. And we published, and we do it, this is after just pulse dye laser. This is combination with pulse dye laser and low-dose isotretinoin. This is quasi-long pulse. We published it. You should do several treatments, and then you really have an improvement of acne. We published the concept of Tixel-assisted photodynamic therapy. You can read the publication. This is relatively old publication. We have really good result after a single session. However, in this presentation, I want to focus on radiofrequency. So again, many publications, if you dig into the literature, you will see radiofrequency works. Now, why? We know, again, this is a study, not mine, that it decreases pore size. This is one fact. We know that if you perform several treatments, it will suppress sebum production. You even have the number, so it's about 40% sebum production after 3 radiofrequency treatment. This is a beautiful study by Judith Helfman from New York. She actually took the inflammatory markers, and you can see there is an anti-inflammatory activities. So of course you should use radiofrequency. Now, which radiofrequency, it's up to you probably to choose. In my hospital, this is the standard of care, especially for the comedonal acne. Now, we did it only for the comedonal acne because we weren't sure for which component, for which, I would say, lesions, it will be more beneficial. So this one is going to be published soon. We chose, I will be very brief in describing the study. This is a study, several centers in which we try to see which lesions is affected more by radiofrequency, the inflammatory, the non-inflammatory. So in one answer, all of them. So the inflammatory as well as the non-inflammatory. However, the inflammatory component will respond better. Now, that's how the patient looks immediately post-treatment. But again, after 3 treatment, monotherapy, quiet, dramatic result. And we see it more and more. Now, we use it as a monotherapy, but we combine. We publish this one if you wait. Patient on isotretinoin, and they come to you and say, please treat me. And I said, no, you have to finish the isotretinoin, and let's have a washout. You're wrong. This is not the standard of care anymore. So we perform, you can see it's 3 arms. So we published it. This is you can see if you do together, you will have in the end less scars, and you have the numbers. So fractional radiofrequency plus isotretinoin, you have 36% reduction as compared to separate, as compared to only isotretinoin, especially when you talk about truncal acne. I convinced you, good. So one mountain was conquered. Now let's go, and I could have talked about other follicular diseases. It's the standard of care in my hospital. But I want to take you to a story. The story starts with this disease, and 10 years ago, a patient of mine, she was treated in the hospital, and when the disease, how many of you heard of hidradenitis? Raise your hand so it's not, okay. So, and she came to my private clinic to be treated for scars. And then in the second session, there was a flare-up, and I said, no, I can't treat you. Go back to the hospital. I said, no, I was waiting, please. And I did something around because I was scared. She came back 1 month afterwards, and she claimed that it really helped, even better than antibiotics. I said, all right, she wants me to treat her, so probably this is not. But I did a second treatment, but this time I really took photos. You will see by yourself. But getting back to hidradenitis, you have many modalities. But in the end, most of our patients are left untreated. In the last consensuses, we can see the first, I would say, reigns of mentioning of technologies. Either if we talk about air removal or CO2, what we call deroofing, or photodynamic therapy. Now, what about radiofrequency? There have been several publications to support the use of radiofrequency for this specific disease. Even in one publication, they took markers. Now, clinically, where do you locate it? How you combine between the treatment? Why it works, okay? I'm not sure we know, but those are speculation. So my hospital, this is the building. I work somewhere here in the second. Okay, you are welcome to visit. So we see many HA patients a year. This is not the first line. So of course, we prescribe, if surgery is needed, surgery, and if biologics, biologics. However, we started offering for the resistant cases, or people who do not want to take oral medication, we started offering this Morpheus 8, this radiofrequency. Now, I'm not going to get into all details in the sake of time. You have to know, because again, not all of you are derms. There is one score, which is called IHS, see here, 55. So how many patients achieve 55% improvement? It's a very important score because in the end, we compare the different modalities to this score. Remember the score, I will get to it in a second. And of course, we evaluated all the rest, the adverse reaction. Let's have a look. So we had 25 patients who completed several treatments. You could see the Fitzpatrick type. By the way, this, the technical team, this is for people who are really see very well. Okay, not 53, because I don't know how any of you were able to see it. You see nothing here. Small. Okay? All right, anyway. Adverse reaction, you can see, but what I want to show you, that whenever we talk about several Morpheus treatment, the IHS 55 was 53%. this is comparable to part of the biologics, which is very, very high. How we perform the treatment, we do ultrasound, so we know exactly where are the lesions, and then we perform the treatment. So we do it focally and all over the area. It's not pleasant. Usually we use tumescent anesthesia, and we have some technique in order to assist with the pain. But have a look. This is the patient before. This is after 1 session, 2 sessions, 3 sessions. Good result. Let's have another one. This is another patient, 1 session, 2 sessions. Have a look. Can you put sound? I asked the patient, and she's describing. Can you put sound? But you can see it's written. So I asked her, what are the changes? She was one of the first ones. You couldn't really understand it. So she's, for example, no sound? All right. So dramatic improvement. Now, one of the main areas that got improved is actually not the typical areas. So not the groin and the axilla. The submammary, have a look, dramatic changes, the nuchal area. So you have to understand that as far as I'm concerned, and when I got into my hospital, the chief of the hospital told me, so you're gonna inject toxin all day? I think I inject less than 0.5% of my patients are toxin injected. Most of my work is actually employing technological or other, I would say, ideas from the aesthetic market and try to work it with people who really need us. And I think this is part of the revolution. And it's going to get into all the branches of dermatology. So the sky is pink, I believe. And I think in the end, it's going to be always the combination of technology medication, combination, tailored approach. Okay, it's not going to be one, let's say, biologics. We have many patients who are on biologics, and still they have resistant areas. We have patients who need a surgery. Now, if I send them to a surgery, it's going to be a major surgery. So I do first Morpheus, I make the disease smaller, and then the surgery is smaller. So it's all about the combination. So thank you so much. And again, always remember, this is the first study. You can, by the way, it was published. So our study was published 3 weeks ago. Just Google me. You will see the study. Or if you don't find it, text me, Instagram, whatever, and I will send you the study. And it's never a one-man show. So I was blessed to have really good team in the private setting and in my clinic. So thank you so much for listening.
Great lecture, Ophir. Thank you so much. Our next speaker would be Peter Wei-Bing Chang with a lecture titled, What's New in Acne Treatment? Thank you so much.
Good morning, ladies and gentlemen. Thank you. So I'll be talking about acne and some of the there is some overlaps with what Ophir's have presented, and I'm glad that he brought it up so that I can just skip some of the slides, right? So mainly I'm going to talk about acne. Now we know acne is a very prevalent disease, right? 8th most prevalent disease in the world, and it definitely affects the psychosocial impact of the patients, right? So in Malaysia, the prevalence is about 67.5%. Among 13 to 18 years old. And you see that in medical students as well. So we published this clinical practice guidelines in 2022. And at that time, when the whole team asked my opinion about how about energy-based devices, how about lasers? Yeah, sorry. This, I think there's auto next slides there. But at that time, I told them the evidence is still not strong enough to actually put in that says that energy-based device is the way to go to treat acne. But now things have changed. This couple of years, more and more evidence that points towards energy-based device that is important in the treatment of acne. Right? So at that time, it's still, if it's severe, then we refer to the dermatologist. So topical retinoids, we know that it is helpful. It's one of the things that we use to treat acne. But we know the problem is the irritation of it. Last few years, we have trifluorotin, but it is still irritant, and it's an expensive topical treatment. So we published the studies. This is in bridging the gaps in the Malaysian, how we use trifluorotin in the treatment of acne, especially facial and truncal acne. There is evidence that it works. This is my patients that I put in the publications. You can see that it works, right? Especially also for truncal acne. But what happened was, patient defaulted after 3 to 4 months. Why? It's because of the irritations. So there's limitation to it. Nowadays, when I use trifluorotin, I will just use it every other night, or sometimes even once or twice a week. And sometimes you apply and then you wash it off during shower. Right? Sorry. Okay, and then we have fixed combination, newer fixed combination of adapalene with benzoyl peroxide. But we know nowadays, benzoyl peroxide, there's a hoo-ha in US about it converting to benzene, which is a carcinogenic. So that's a problem that you have to advise the patients on that. And topical clascoterone, just like what Ophelia mentioned just now, we say that those days when a patient comes to us with oily face, what can we offer? We can only offer isotretinoin that reduce down the oiliness. But nowadays, we have topicals, like topical clascoterone. It helps to reduce the sebum production and pro-inflammatory cytokines as well. There's anti-inflammatory property in it. We have isotretinoin. We also have our lasers to cut down the oiliness of the skin. So we are in the midst of publishing this study, also consensus papers, to look at how these topical androgen inhibitors helps to treat the acne. Right. Sericycline, a narrow spectrum because we don't want to kill all the unnecessary bacteria there, your Cutibacterium. Even Cutibacterium, there are good ones, there are bad ones, so you shouldn't wipe out all the Cutibacterium. Right. Now, photodynamic therapy, it works, but again, it can cause unnecessary irritations to the patients. And we have all this light-based treatment for acne that have been mentioned just now. The only problem is it is not selective. So what we are trying to do is to use other chromophores, like your water, like your red blood cells, your blood vessels, all this, to try to heat up the sebaceous gland from outside rather than from inside. And Orphe mentioned just now, these studies, one of the studies that look at whether isotretinoin alone versus laser versus fractional radiofrequency. Now, which group has the lowest risk of recurrence? And you find that fractional RF microneedling has the lowest. And this is one of my staff that I did the fractional RF. You can see that obviously the acne improved. And not only that, you tighten the skin, you improve the sagginess of the skin. So nowadays, if a patient wants, comes to me with a saggy skin, and at the same time with acne and the acne scars, I think fractional radiofrequency, microneedling RF is my first choice. Now, again, this study looking at whether or not isotretinoin alone versus isotretinoin by RF, which one is better? So the combination actually works better in terms of reducing the acne. Now, we know that the more sebum that you have, the worse the acne is. So that's why the sebaceous gland activities is one of the main pathogenesis of acne. And therefore, you have the 1726 nanometer wavelength, which is targeted to the sebaceous gland. And it has very high power, sapphire cooling to cool the epidermis, and is suitable for all skin types. So when you look at how selective 1726 is, it's actually 2 times more selective compared to water alone. Right? And then whenever we talk about lasers, we talk about wavelength, we talk about pulse reduration, thermal relaxation time of the target. So the thermal relaxation time of sebaceous gland, we know is 60 milliseconds. So in order to target effectively is 50 milliseconds. The pulse duration of this 1726 nanometer is 50 milliseconds. So it's just enough to destroy the sebaceous gland without affecting the surrounding tissues, because we don't want the melanin to be affected, right? Your melanocytes to be affected. And what about the spot size? It's 3 millimeter. It's just nice to target the 1.5 millimeter depth of the sebaceous gland. But it may not be enough to target our truncal acne, because we know that our skin of the trunk is very thick. So it's not 1.5 millimeter, it's deeper than that. So that is why there are some case reports that says that it works for truncal acne as well. But personally, I don't use it for truncal acne. So you can see some of the histological studies before and after the lasers. So the pivotal studies is to look at doing it once a month for 3 times, and then they look at the patient after 6 months and 12 months. And they found that 80% of the patient had at least 50% improvement in terms of reduction of inflammatory lesion counts after 3 months. And at 1 year, despite not doing anything else, 92% of them had at least more than 50% in terms of inflammatory count lesion reductions. But it's not as helpful as comedones. Just now we talked about comedones, inflammatory. So this is more inflammatory, rather than comedones. But it still works for comedones. If you can see that 40% of them at 1 year is reduced. Safety-wise, very safe. Some of them has this acne flare. About 40% of them had acne flare, that's all. But pain is something that we need to address carefully. So we use a lot of things like even your COX-2 inhibitors to reduce the pain. Otherwise, it can be a very painful procedures. So long-term wise, you can see that at 4 years, some of the patients still has almost clear acne. And this is real-world data from a single site to look at how effective it is in a real-world study. And after this 12 months and 24 months, you can find that IgA improvement, clear or almost clear skin, 75% had clear or almost clear skin at 24 months. I can't promise cure, but I tell my patients, you may have a long term of duration between the relapse of acne. Yeah, long-term remission is there. So this is some of the studies. And this study look at how about if we combine everything, because in actual fact, we don't sometimes treat just with lasers. We combine with the isotretinoin, you combine with your topicals and everything. So this is another real-world study. They combine everything, and at this primary endpoint is looking at IgA score of more than 1 point. Basically, almost everyone had reduction in terms of IgA because you combine everything. And it is safe also to combine all these treatments. So like, for example, this patient, he combines tretinoin, clindamycin, and spironolactone over there. And also they suggested if at 4 months, if you still have the lesion acne, you can go for your 4th session, 5th session, and even 6 sessions. So it doesn't mean that you have to stop at 3 sessions of the treatment. And of course, you can combine with other things like spironolactone, topical retinoids, oral antihistamine. So these are some of the before and after. Also combining with other mode of lasers like your XLV. So the strength of 1726, I find that is for patients who had relapsed. For example, we stop isotretinoin, patient comes back. Then, of course, the next treatment, let's try 1726. Who doesn't want oral treatment? Who's athlete? You know, athletes, higher testosterone, higher acne counts. Who's non-compliant, teenage boys, I always say they're not very compliant with even topicals or oral. Who have side effects to oral medication like lip eczema so badly. Oily skin, who wants non-invasive, minimal downtime. And any skin type, basically, you know, even your skin type 6, who wants longer period of remission, and obviously patient who's planning to get pregnant. Even pregnant ladies, very difficult for us to start oral antibiotics as well. So, and just now I mentioned, right, truncal acne, the depth is the problem. So nowadays, they are coming out with the bigger spot size, try to achieve a deeper count there, So sebaceous hyperplasia is one of the, because sebaceous gland is the target, right? So theoretically, it should work for sebaceous hyperplasia. But at the moment, it's still ongoing studies to look at whether it's that effective. This is feasibility studies. They show that you can see it is reduced It reduces the sebaceous hyperplasia there. I just want to show you some reports of a case. 19-year-old Chinese girl presented to me in 2019 with acne and lip eczema. Once you have lip eczema, it's like, isotretinoin may not be the first choice, right? But after discussing the patient still chose that, but then later on defaulted. He came back again last year, again with oily face, and she complained of deep-seated nodules, acne, nodular cystic acne. So we finally started this 1726 nanometer. So you can see that it helps. You may be wondering, like, is this a candidate for 1726 nanometer? It doesn't look like there's anything there. But if you feel deeply, there are actually nodules there. And these nodules are the ones that can cause deep scars there. So this is 4 months after 3 sessions. So 6 months after, 6 months after 3 sessions. So she was very happy, no nodules. She felt that the oiliness of skin has reduced dramatically. Case 2, 13-year-old Chinese girl presented to me in October 25 with acne for the last 2 years. Started on topicals, and every time when we talk about it, of course, some patients, they want to go back and think about it. So the first session was started in November, and this is 1 month after. 1 month after second session. After third sessions. So it works basically. So how do I treat acne? It depends on the severity and type of acne, age of the patients, the compliance, whether there's pregnancy risk or not. I'll explain to them all the modalities available. And patient's preference also, like I mentioned just now, some patients will come, tell you, I don't want benzoyl peroxide already, I don't want topicals, I don't want oral, some say I don't want lasers, you know. And of course, we need to talk about the cost of the treatment, because when it comes to lasers, the cost escalates. Topicals, cleanser, moisturizer, sunscreen, topical retinoids, clascoterone, oral, isotretinoin, doxycycline. Sometimes I even use colchicine and Dapsone, especially for our acne conglobata. Yeah, and adjuvant treatment like intralesional triamcinolone, chemical peels, microdermabrasion, low-level light treatment, and also 1726 is, as mentioned just now, the indication. So there's no cure for acne at the moment, but 1726 may offer patients longer-term remission. Oral isotretinoin remains the most effective therapy for moderate and severe acne, and topical treatments are important for long-term maintenance. So with that, I thank you. Sorry for the slides flipped through at the end there. I think there was some setting errors there. Yeah.
Thank you, doctor. So I will invite Dr. Anon Paichitroyaya, referring the theme Demodex in modern dermatology, the missing link in acne, rosacea, and treatment-resistant facial dermatosis. Thank you, doctor.
Good morning. Thank you for your interest. Let's begin. Today I will discuss about the Demodex in modern dermatology, the missing link in acne, rosacea, and treatment-resistant facial dermatosis. Let's begin with this patient, 40-year-old woman with acne has been treated with retinoid, antibiotic, or even isotretinoin for more than 2 months, show only slightly improvement, right? In a case like this, normally we use escalate our treatment. But what if the issue is not the treatment, but the diagnosis, right? Because everything that appears to be acne may be not the real acne. Demodex is a normal part of the skin microbiome. It's along with the C. acne, malassezia, and even the staphylococcus. Under normal condition, all of these organisms are not harmful. They are part of balanced microbial environment. The problem arises when this balance is disrupted. The Demodex begin to contribute to inflammation that we call demodicosis. Actually, our skin immune system play a major role in controlling this balance between Demodex and the host. But however, Demodex can evade our immune response. It can reduce immune recognition. It can improve the immune tolerance. So it's allowing Demodex overgrowth. The disease usually occurs when this balance is disrupted from control, coexistent to immune dysregulation and inflammation. How can we diagnose demodicosis? Because Demodex can found on normal healthy skin, right? So my detection alone is not enough. We have to correlate with the clinical presentation and the treatment response. So we have to combine with the clinical suspicion, increase Demodex density, and also clinical improvement after a calicidal treatment. We can detect the Demodex on our skin by using imaging technique, dermoscopy, confocal microscopy. If you want to assess the density of the Demodex, we can use a standardized skin surface biopsy. Or for the pustular lesion, I use a superficial needle scraping. Right now, because the emerging technology of artificial intelligence, AI, can help us to predict high Demodex density using facial photograph combined with the clinical data. It can improve the accuracy of the diagnosis from 63.7% to 70.6%. However, instead of replacing clinician, right, it's still only the tool that can help us to improve the diagnosis and help us to detect the patient who may benefit from further Demodex evaluation. Let's see the clinical presentation of the Demodex in our real life. Most of the patients do not present with the papulopustular lesion. Many of the patients complain of dry, roughness skin, sensitive skin, and persistent redness. Sometimes you have to use the overhead lighting. It will more easier to see the roughness and the sandpaper-like skin texture. This is a pityriasis folliculorum, a classic presentation of demodicosis. Roughness skin, dry, hypersensitive, and follicular scale from the heavy Demodex colonization within the hair follicle. This is usually the minimal inflammation, so it's often underdiagnosed. And Demodex can also mimic many common inflammatory skin disease, such as in this case, present with a dry, scaly patch on the eyebrow and perinasal area. At first scan, the diagnosis should be seborrheic dermatitis. But however, if we look carefully on his cheek, we can see the dry, scaly skin and roughness. That subtle sign is an important clue to think about the Demodex involvement in this case, in this patient. In this case, it's present with the multiple inflammatory papulonodular lesion on the cheek, chin, and jawline. It looked like acne, right? But there was no comedones. In this case, the real acne patient present with multiple comedones and some inflammatory papules, but he also have dry, roughness skin and follicular scale is a sign of the Demodex. That means Demodex can also coexist with the real acne patients. Same as perioral dermatitis, Demodex can either mimic or even coexist with this condition. In this case, he show up with the acne-like lesion together with the seborrheic dermatitis-like lesion, demodicosis. So sometimes it can confuse us with the abnormal presentation like this. In this case, the patient was thought to have a chronic unexplained facial eczema. After the steroid treatment, he get improved, but kept coming back after stop the steroid. Even we do the extensive evaluation, many times PET, we cannot find the cause. But he get improved after a calicidal treatment. So in the patient who have a recurrent steroid-dependent facial dermatitis, Demodex should be the one of the possible cause that we have to consider. And this case, she presents with a erythematous patch with telangiectasia. It looks like the mala rash from LE, but ANA negative for many times. And she get improvement after a calicidal treatment for 2 months. So Demodex can be sometimes look like the LE lesion too. And this is another presentation of the Demodex. They can present with a scatter, multiple, itchy skin color or mild erythema papu that look like the insect bite reaction. You can see that demodicosis can present in many presentations. Most of the patients may present with a dry, roughness, sensitive skin, but others maybe develop persistent facial redness and scatter of the papu. This combination also seen in this patient too, dry, roughness skin with papulopustular lesion. And it also can mimic the rosacea, both erythematotelangiectatic rosacea and papulopustular rosacea. And interestingly, I saw many cases that have the rosacea-like demodicosis that present with both clinical of rosacea, erythematotelangiectatic with a persistent facial redness, flushing, and later she also developed the papulopustular lesion, like the papulopustular type of the rosacea. Same as this patient. Progression from flushing, telangiectasia to multiple papulopustular lesion. And some cases of rosacea-like demodicosis can affect only the node. So make it more look like to the real rosacea. If the clinician do not specifically think about Demodex, the diagnosis can easily be missed, right? It also can involve the eye, right? Many patients also complain of the dry eye, irritated eye, and blepharitis. In some cases, also have a recurrent sign from this Demodex. Let's go back to the first patient from the beginning. After a calicidal treatment for 2 months, she getting improved a lot. Not from the stronger medicine, but from the treating the right condition, right? So the key message is whenever we saw the patient who did not respond as expect, maybe we have to step back and rethink. Is it the real acne or is something else, right? And don't forget to consider the Demodex is the master of mimicry. Thank you.
Thanks so much. Our next speaker is Janine Norgdes, and she will talk about 1726 nanometers laser targeting sebaceous gland, treatment for acne and eye bags. Thank you.
Thank you very much for having me today. And since the podium is very tall, I would like to use the space next to it. So I'm Dr. Janine Norgdes from the Faculty of Medicine, Siriraj Hospital, Mahidol University, Thailand. So what I'll be talking about today is the 1726 nanometer laser. Has anyone tried these lasers yet? I see some of you have, some of you haven't. So just while we're waiting for the slides, okay, so the 1726 nanometer laser is a new wavelength that actually targets the sebaceous gland. So to see how it works, it's kind of a diode laser. So you can see that the absorption of sebum at this wavelength is better than water, about 1.8 times higher than water. So it selectively destroys the sebaceous glands. So in this picture, you could see the pathology of the exposed sebaceous gland to the 1726 nanometer laser. So, oh, I'm sorry, my slide isn't going. Okay, so On this side, you could see that the sebaceous glands were destructed. You could see the irregularity. The inside sebaceous glands weren't formed really well compared to the unexposed part that are still well formed. So FDA has approved this kind of laser for mild, moderate, and severe acne. So it's different from medications that, oral antibiotics or oral isotretinoin are only FDA approved for moderate or even high severity of acne. But the 1726 nanometer can actually treat all acne from mild, moderate to severe. The good thing about it is that you don't have to take any oral medication, which sometimes also has side effects in some people. And such as if you take oral doxycycline, you may have those nauseous part. If you have taken the isotretinoin, you also have to be careful of the hepatitis, of the hypertriglyceridemia, or even of depression. So that's why it can have some side effects that we do not want. However, usually for acne, we usually treat it 3 sessions, 4 months apart. The good thing about it is it also has a sapphire cooling contact as well. So actually there are multiple wavelengths when they started this machine that actually targets the sebaceous gland. But however, they chose to do the 1726 because of the coefficient that is higher than water, about 1.8 times. So what we already know is that it works really good for sebaceous glands and also acne. But however, there are also unapproved FDA use, which we did a study at our hospital. So you could see that one of the problems in these days is we have those eye bags. The problem of eye bags are kind of a diversity. Some is because of the bulging fat. The others are because of the sunken skin or the loose skin underneath the eye and the thick muscles. But if you look closely, you could see that all the separated fat that's protruding might be because of the aging causes laxity of the ligaments underneath or even the skin that is above. So we did a study using the 1726 nanometer laser for 3 sessions, 4 weeks apart, and the setting was similar to what we use in acne treatment. The fluence is about 19 to 22, and we did 3 passes. So you could see that the under eye actually has a lot of skin here, and if you look closely, some people have those white dots and white bumps underneath the eyelid. That is the sebaceous gland, so that's what we're trying to target actually. So we did a study to prove the efficacy and safety of the 1726 nanometer laser for the treatment and rejuvenation of lower eyelids in Asian. This was conducted at our Department of Dermatology, Faculty of Medicine, Sirat Hospital, Mahidol University. So we gathered 20 patients aged about 48 years old and mostly for female with a Fitzpatrick skin type 4. So we did 3 treatments overall, and the pain score was about 5. So it was well tolerated without any topical anesthesia at all. And we did about 50 shots per side. And the fluence was about 19. Some people tolerated up to 22, but mostly did not because it was quite painful as well. Patients guided the improvement score very good. So let's see the results first. So when we measured the results, of course, we wanted something to be objective. So we wanted to measure it with Vectra to see the volume 3D of each patient. And we measured the eye bag. You could see this is kind of a preliminary study for you all first, so we only have to follow up until 1 month after completing 2 treatments. So this is just only with 2 treatments. You could see that it significantly decreased the eye bag volume compared to before the study, and the trend is going lower and lower. As for the color of the skin around, we also measured melanin with mexameter, which also improved slightly, but not as much. As for the erythema under the eyelids, it did not improve that much at all. And also, if we measured the texture with Antera 3D, we could also see that the texture of the skin improved significantly as well. So these are the images from Antera 3D. You could see that the crow feet are a little better as well. And the wrinkles at this area also improved significantly after 2 sessions only. And the texture at the infraorbital also improved significantly. And the indentation also improved. So there were some adverse effects as well. So some people had scabs, especially when we used higher fluences. And we had scabs about 8% in 40% are about 8 patients, and then we also had erythema about 10% as well. Some people also experienced swelling, which lasted for about 1 to 3 days, and also one patient that we did very high energy. She had a vesicle in the medial part of her eye. Some people experienced PIH and hypopigmentation as well. So let's see the clinical photos. So you can see that this patient started out with a lot of eye bag underneath both eyes, but at 1 month after treatment, her eye bag actually shrinked a little bit. And you could see that the results of the eye bag shrinkage continued up until 1 month after doing 2 sessions only. So this is baseline, and this is 1 month after completing 2 sessions. You can see the bulging underneath actually got down a little bit as well. This is another case of severe eye bag. You could see her eye bag bulging, lower part of the eye, and this is 1 month after completing 2 sessions. You could see the bulging actually decreased. And this is the last case. Okay. So you can see that the eye bags have improved. Okay. So this is the volume with Vectra. You can see that the blue color means that there is decrease in volume. Okay, so just for conclusion, so the 1726 nanometer laser works really good for acne, as many reports, and I think some of us already has experience with it. But newer indications are also interesting. So this is one of the newer indications, but not FDA approved at the moment, to treat the eye bag bulging under the eye. So thank you very much.
Thank you, doctor. So Dr. Peng Hussein Lipeter, and the title of presentation will be a multi-layer, multimodalities treatment for atrophic acne scars in Asian patients. Thank you, doctor.
Okay, thank you, Chairman, for the kind introduction. So I will present the treatment of acne scar. We hear a lot of the presentation about acne treatment. So this is my position in different societies. So disclosure nothing for this talk. So we, starting from some of the facts, we know the acne, as a previous speaker mentioned, is the most common, one of the most common skin disease. In some of the reports, they can affect more than 19% of the teenagers, and more than 50%, they will have some sequela, like pigmented sequela or the scar formations. So for the PIH, it's quite common in Asian, especially in Asian population, and it will last longer compared with Caucasian counterpart. And PIE also very popular, especially in Asian patient. So one of the common questions a patient may have, can the acne scar spontaneously resolve? So usually, the answer is yes, it's for PIH and PIE. But in sometimes, some of the study already shows this kind of sequela, pigmented sequela, even can last years. So the same question for the atrophic scar or hypertrophic scar usually is not. They will not spontaneously resolve. And even with aging sagging, they will be even worse. I have some of the patients, they treat, he or she want to treat the acne scar in the age of 40 or 40 plus. So that's, this scar get worse. So we know that's a lot of different types of the scars, rolling type, box scar, and ice pick scar, and the elevated hypertrophic scar, even the keloid scar. And we know they have a different widths and depths in terms of this. Like a box scar, they have a shallow type and a deep type. So if you take a look how deep it can go, by some of the histology studies, it can sometimes go very deep. Even to the not only the dermis, they can go up to the subcutaneous fat. So this is from one of the book. You can see this classification. They have a macular type, that's the color change. So like a PIH, PIE. So the depression, like we mentioned the 3 types, but here is more like a linear, atrophic, or lipotrophic. Lipotrophic especially is a fat atrophy in the subcutaneous layer. That's in the 5 layers is layer 2. In our skin is fat layers. So also they have other types of the elevated scars. And usually they will mix all these types of the scars. So this is from publication of the dermal surgery. You can see we have many methods to treat the scars, like lasers, puncture elevation, subcision, TCA, etc. A lot of different methods to treat. Take a look at this patient. This patient have the acne scar, and also he has some different types of the atrophic scars, and also of the PIH, PIEs. So how can we treat a patient like this? So a simple diagram, I take a look at this patient. If the patient have PIE, first things I can use like a dye laser or long pass 532 to treat. This is one of the examples. The patient have a PIE all over the face. And this is a treatment after 3 dye laser treatment. And this patient have a very interesting story because you take a look at the after treatment. At that time, the patient came back and complained there's no effect of the treatment. And I take a look at the before photo. I think your result is quite nice. So patient do forgot. So please take photos. We forgot, and the patient also forgot. Yeah. So, yes, for sure. Yeah. Sometimes you encounter this kind of conditions. And for the PIH, some PIH is due to the acne. Some may be due to the previous treatment, like fractional lasers. So for this, I use like a Pico's second laser, Tony, or fractional lasers. This is the example. The patient post non-ablative fractional laser have some PIH, and we're treating with fractional Pico, and improves the scar and also improves of the PIH. And next, you need to consider not only the atrophic. Some patients may have a fibrotic, even elevated, mixed with atrophic scars. So this we need to consider like a LADD in conjunction with a laser or other device treatment. So we know the LADD, that's a more effective ablative one than the non-ablative one. Even the microneedling RF fractional Pico could be aiding increase the absorption of these drugs. We can use this. This is one of the example you can see. So after 2 laser and the LADD, you can see the improvement of the atrophic scar and also the keloid-like scars over the mandible area. So another thing that we can consider is that the scar have an underlying fibrotic band. You can, theoretically, the rolling scar have a fibrotic band, but in clinically, I find some of other type of atrophic scar also have. You need to use your hands to pinch, to test. So we can do like a subcision. We know subcision, you use different tools. You can use like a no-co needle or use 19 gauge needle. But in clinically, I prefer use a smaller needle like a 23 gauge or 21 gauge. And even sometimes we even use even smaller. And you use cutting back and forth and likewise, and through 2 entries, different direction, that will get the better result. So this is one of the example. We combine the laser and the subcision to improve the scar. The result is quite nice. So next consideration is the patient have a fat loss. We mentioned about the lipoatrophy. So if this, I will combine like an injection of a biostimulator, PLA, even the HA filler. So this is an example. You can see some of the atrophic scar. Also, the large area is atrophy. You can take a look at this 15 months after we do 5 pico and also 2 injection to overall volumization of this lipoatrophy. So this is another example with treating with the fractional pico and also with the HA injection. You can see the improvement of the skin texture. So lastly, we will consider the efficacy and the downtime. You can combine different modalities. In my hands, like a picosecond laser, ultrapulse, and ultra-clear microneedling RF, and the PDLA with needle-free injectors, mix in between. Like you do the very strong fractional lasers, and in between you use fractional picos, and also you combine the injections like a PDLA. This is a case from our previous publication. You can see this by picosecond laser long-term follow-up. They improve the acne scar quite a lot. And also, we can use like this. This is atrophic scar over the glabella. Nice improvement after laser treatment. We can use different modality like laser, energy-based device, fillers, substitutions. We have many modality we can use. And usually, you need to wisely combine all these modalities. So like this case we showed before, this is after 6 years, many different modality in combination to treat to get this kind of result. I come to the conclusions. We have many modality we can use. Needed to consider, is there PIE, PIH, there's a hypertrophic scar mix and the underlying fibrotic band, and also deep fallen loss, and then consider different modalities. With that, I'd like to invite you to ISDS meeting in Hong Kong. We cooperate with 2 Hong Kong society and cooperate with Professor Henry Chen in Hong Kong first weekend in December. You are all welcome to join us. So with that, I thank you for your attention. Thank you.
Thank you, Doctor. So it's my pleasure to invite the chair of the session, Dr. Fernando Valenzuela, drugs for hidradenitis, the decision matter. Thank you, Doctor.
Good morning. Thank you so much. It has been a pleasure to. It's my first time here in Thailand. It's great. I will talk about a very complex disease, hidradenitis suppurativa. It's something very difficult for us as physicians and for the patient. They suffer a lot. It's a very impactful condition. So we try to do our best to help the patients. These are my conflicts of interest, but none of them is really important today. So the decision maker, it's very complicated because we have to go to different aspects. First, the severity. We have some ways to measure the severity of HS, the number of abscesses, the nodules, HS4 or the Harley stage. Also the phenotype, we have to see if the patient has a nodular condition or it's more with tunnels and scarring. And what about the activity? It's continuous, they have some flare-ups. So we have to also take in account the comorbidities of the patients. Most of them are smokers and they have the whole metabolic syndrome condition, and of course the goals and the access for the patient. If they want something really fast versus durability, what are the things that we have available in our countries, etc. Here is the pathogenesis of HS, and basically we have different stages. The first one, is the follicular occlusion. Then we will have the rupture and the flare up with the innate and also the immunity, and we will have those cytokines, the TNF, interleukin 17, interleukin 1, interleukin 36, and all of them working via JAK-STAT. And then we will have the chronic condition, the tunnels, and the scarring. So we can now intercept every single of those cytokines, and so we are able to provide a better outcome for the patients. But also, we can use another things. So my idea is to present you this escalating therapeutic later, where we will have different ranks, and I will talk about a little bit about all of them. And for sure, we will basically combine different therapeutic options. The idea is started always with the first one because it's really important for the patient to understand the inflammatory condition he or she is suffering. And the lifestyle, it's not something that we can advise at the end of the session. It's really, really important. We know that, for instance, about smokers, around 70 to 90% of our patients are currently former smokers. And the impact, we know that if the patient stops smoking, we will reduce the flare-ups and we will improve the severity of the HS without any other antibiotics or biologics, whatever. So it's important to advise our patient to stop smoking. It's not only like an alternative idea, it's crucial. And also about the weight loss and the metabolic care. We know that if the patient is able to diminish the weight, we will directly diminish the inflammatory lesions. So screen aggressively for metabolic syndrome, insulin-resistant, ovaric polycystic, and use metformin, which will be part of our rank 2. And this is rank 2. Again, this is crucial for the patients to understand, and we will use both in most or maybe all of our patients. And first of all, we will use metformin. We will start 500 milligrams, and we will escalate up to 2 grams a day. We know that we will diminish the insulin resistance, but also we will reduce the androgens, and we know now that metformin is a very important tool to live longer and to have more youth. So even when some of the patients are resistant to metformin, I think that when we explain why are we using the drug, it's easier for them to understand. So it's clear that we can impact and we can reduce the inflammatory lesions using metformin. And also using thin gluconate, 90 milligrams a day, we have anti-inflammatory and immunomodulatory effects, especially in Harley 1 and 2. So when patients are not so severe, it's a very, very good idea to use zinc. Of course, it's not going to be our monotherapy, but it's important to help our patient in many different ways. Let's go to rank 3, especially when we want to get a local control on some of the lesions, maybe a fistula, maybe a nodule. We can use topical clindamycin. It's a very good idea in some lesions, but remember, we have to use benzyl peroxide try to diminish the resistance, and it's not going to be a very long-lasting treatment. It's going to be maybe 6 to 8 weeks. We can use resorcinol, and it's a very good keratolytic agent for the painful nodules, and it's also proven to really work well in HS. And also we can for sure use triamcinolone intralesionally, and especially when we have 1 or 2 nodules in flare-up, it's a very good idea to diminish the inflammation locally. However, most of our patients will need more. So this is the rank 4, the systemics and anti-inflammatory agents. So for mild to moderate HS, we will use tetracyclines. It could be doxycycline or minocycline. And it's going to be a good idea. Remember, patients must be older than 8 years of age, and we will have the use of doxycycline or the tetracyclines, not due to the antimicrobial effect, but it's because of the inflammatory effect. When it's more moderate, we can use clindamycin plus rifampicin, and when it's severe one, we can use the triple combination with moxifloxacin, rifampicin, and metronidazole, or even better, but unfortunately it's intravenously, ertapenem. And we can use also some collaborators. We can use anti-androgens, especially spironolactone or contraceptives in a female and hormonally driven HS. So we have to screen for PCOS and see all the metabolic syndrome on this population. We can use acitretin or oral retinoids, especially in the follicular phenotype. Because if a patient has a lot of tunnels and drainage, it's not going to work. We can use dapsone in some of mild to moderate disease, but it's really modest effect. And we can use systemic steroids, but it's going to be only in a short term in a very severe flare-up. Remember, this is like complementary. It's not going to be like our first steps. And we have to aware the patient that they will not last longer. Remember, we have to understand the pathogenesis and the phenotypes. So for some patients, the most important clue will be to try to diminish the follicular occlusion, but for others, we will try to diminish the chronic inflammation, and then we can use some of the biologic and small molecules. So rank 5, the biologics, those are FDA approved. And we have basically 3 pillars. The first one is adalimumab, which was the first one. It's a TNF-alpha inhibitor, and we can use it in adults, also in adolescents. And we have a lot of data on adalimumab. The second one is secukinumab, which is an interleukin-17A inhibitor, and we can use it from the age of 8 years and above. And now we have also bimekizumab, which is an interleukin-17A and F inhibitor, and it has shown very good results. Please be aware that we have to wait at least 48 weeks to see if the biologics are working, because we have an initial response which would be on week 16, but our best response will be on week 48 or in week 52. And the definition of if the therapy is working or not is basically HISCR 50, which means that the diminish of 50% of the abscesses and nodules. And we're doing very well with biologics, but we have to remember that it's not psoriasis, so some of our patients will need much more. We have the rank 6, the new era of treatments, and just to show you, we will have nanobodies and proteins in the future. We can maybe have in the future interleukins like lutikizumab or spesolimab. Actually, spesolimab did not work well in clinical trials. We have povorcitinib, upadacitinib, which it's a JAK inhibitor, and both of them are in clinical trials. I think that upadacitinib will be available very soon, and we can have some oral inhibitors such as remibrutinib. The idea is to be more focused and maybe have multiple ways to cut the inflammation. So just some things at the end. If we have a Harley 1, it means that it's a mild to moderate condition. We can use topical clindamycin plus benzoyl peroxide, resorcinol for painful nodules, intralesional triamcinolone for flare-ups, and we can use doxycycline. In Harley 2, we can use the antibiotics, but please escalate early to biologics because this is the population who would be most beneficial when we start using biologics. We can use hormonal therapy if it's a female phenotype, and we can use localized surgery. And for Harley 3, it's a very severe one. Biologics are the first option, and we can use the combination. And also, what we have learned today, we can use a lot of technology to help our patient to diminish the pain and the nodules and the sensation. But always, for all of our patients, we have to please take a look at the modifiers. Stop smoking, address the metabolic syndrome and the PCOS, use metformin and zinc, treat the pain and the depression of the patients. More than 60% of those patients have depression, and of course those patients will not adhere well to our treatment, and they will feel really, really bad if our treatment options are not working. So please take a look at the depression and anxiety of our patient, and restage every visit and escalate soon. So just to finalize, we have to first see the stage of the patient, then prescribe. The foundations are not optional, so this is crucial. Sometimes we based all of our treatment options on pills, medication, biologic, etc. But patient must be aware that is his or her condition, so they can help us to improve their quality of life and their health. So this is very important. We can use antibiotics, but for sometimes we have different types of biologics nowadays, and I think that the newer things will be oral. Those are my clinical sources. Thank you so much for your attention. And to finalize this symposium, it's my pleasure to present you to Monica Fida. She's from Albany, and she will talk about pyoderma gangrenosum, rare but exist. Thank you so much for being here.
Thank you, everybody in this room. It's my pleasure and honor to be part of IMCA's family. And my talk today will be pyoderma gangrenosum, a challenging diagnosis and treatment. Of course, it's rare, and we have to take in consideration. I do not have any conflict of interest to declare, and I will start with a short definition. What is pyoderma gangrenosum? It's a rare, non-infection, ulcerative skin disease which often may affect the mucoses, either mucous membranes. It's a neutrophilic dermatosis, a group of disorders characterized by skin lesions for which histologic examination reveals intensive dermal infiltrate composed primarily of neutrophils. Yes, it can be mostly associated with other diseases in about 50% of cases. Was first described by Brock in 1916 as a phygedenism geometric. And then Brustin named it pyoderma gangrenosum, and at that period of time, it was thought to be a disseminated of a localized infection. But actually, we think differently. We think as dysregulated immune system. So based on cytokine storms, cytokines interleukin 6 and interleukin 8 and genetic predisposition. Aim of this presentation is to emphasize the role of early diagnosis of pyoderma gangrenosum as a rare disease, part or orphaned list, to show our experience in the diagnosis of the disease, the comorbidities, and treatment options. These are some photos of my patients treated with diagnosed and treated with pyoderma gangrenosum. And as you can notice really different cases with vegetative, bullous type, ulcerative types. So take a look on these cases and rethink for different diagnoses, how to diagnose pyoderma correctly, and then to start it correctly. We started with a rare case in our publications, with a rare case of pyoderma gangrenosum on the hands. And you can see here very well this case and either ulcerative type of pyoderma gangrenosum. Is it rare? Yes, pyoderma gangrenosum is a rare disease. 2 to 3 cases in 100,000 people in the United States. But actually, to be sincerely, we are noticing more pyoderma gangrenosum than we were noticed before. It may be due to increased cases or due to our knowledge to diagnose it correctly, pyoderma gangrenosum. The incidence rate is 3 to 10 million population each year. Occurs, of course, in both sexes, but woman has the incidence a little bit higher than man. Affects all ages, but the peak of incidence occurs between 4 to 5 decades of life. Do we have cases in infants? Yes, we have cases in infants, and there are reported around 4% of cases of pyoderma gangrenosum in infants, and especially in adolescence age. In this chart, I found it quite helpful, the whole scanner of pyoderma gangrenosum, starting from pathology as a dysregulated immune system with genetic predisposition, different clinical cases in everyday practice with bullous atypical elements, pustular elements, vegetative and ulcerative elements. And as I mentioned before, is quite evidence in pyoderma gangrenosum associated disorders, especially inflammatory bowel disease, hematologic disorders, arthritis, pyogenic arthritis, pyoderma gangrenosum, acne, Papa syndrome, and Papa's syndrome, and followed by scarring, infection, loss of mobility in some cases, and uncontrolled pain, and of course, depression of these patients. How it starts in pathology, you can notice very well that it starts as a papule, then it can be ulcerated, a central ulcerated and atrophic scar is evident. We diagnose the pyoderma gangrenosum. The major criteria is biopsy on the side of the ulcer as neutrophilic infiltrates. Neutrophilic infiltrate is the key of diagnosis of pyoderma gangrenosum. But it's hard to diagnose pyoderma gangrenosum because there are lots of number of different diagnoses, starting from infection, ulcer, different diseases, and either tumor diseases. Minor criteria that we have to take in consideration. So 1 major criteria, biopsy, and 4 minor criteria, excluding infection always. Pathogen test is quite important in pyoderma gangrenosum. Personal history of irritated bowel disease or inflammatory arthritis, history of a papule, pustule, vesicles that ulcerate rapidly, peripheral erythema at the border of the lesion and tension on the lips of the ulcer, multiple ulcers sometimes, and cerebriform scars or wrinkled paper at the site of the healing. And is quite important, a reduction of ulcer size within 1 month when we start immunosuppressor, corticosteroid or azathioprine treatment. So within 1 month, you see the improvement. Start with high doses, in fact. That is quite important. In histopathology, you can look on histopathology, but important are the data for type of the lesion, to refer to histopathology doctor, the site of the lesion where you took the element, the stage of the lesion evolution, and the treatment that has been used. And typical histopathology findings include central necrosis, ulceration of the epidermis and dermis, and neutrophilic infiltrate. These are some pictures of histopathology, and this one is one of my cases treated for pyoderma gangrenosum with malignant type of pyoderma gangrenosum, because we know very well that if it is on the face, it is a malignant type of pyoderma gangrenosum. Approaching treatment of pyoderma gangrenosum through years. As I mentioned before, at the beginning, it was thought as an infection theory predominates in the base of pyoderma gangrenosum. So at the beginning, it was treated with antibiotics. Then after, it was immunological theory that predominates. And you can notice very well that starting from 1990, we tried to treat pyoderma gangrenosum either with immunosuppressor, cyclosporine, azathioprine, and corticosteroid. Where we are actually, we are in the area of autoinflammation theory that predominates in the pyoderma gangrenosum, and actually we are treating pyoderma gangrenosum with anti-TNF-alpha, with interleukin and small molecules treatment. These are last studies that I mentioned. New reports suggest us to think deeper than the skin. Why? Because pyoderma gangrenosum, as I mentioned, is quite important to treat pyoderma and either other diseases under the skin. So the most common is inflammatory bowel disease, arthritis, solid organ malignancy, and hematologic malignancy. And this paper suggests that pyoderma gangrenosum cannot be considered just a separate disease. We have to check and to evaluate carefully comorbidities and other diseases that are together with pyoderma gangrenosum. Yes, underlying conditions, they are quite important either for the prognosis in the treatment of pyoderma gangrenosum. This one is a must for dermatologists that treat pyoderma gangrenosum. How we treat today? Referring this paper and referring other papers and our experience, we treat pyoderma gangrenosum with anti-interleukin treatments. Secukinumab is actually a treatment of choice, and other small molecules, either anti-TNF-alpha, infliximab, adalimumab, and etanercept. Quality of life. Yes, it affects a lot, pyoderma gangrenosum, the quality of life of our patients. I mentioned before that there are ulcers and there is a pain that affects the quality of life of these patients. And it is reported that around 10% of individuals with pyoderma gangrenosum, they suffer from depression. That this is quite important to take in consideration when you treat your patients with pyoderma gangrenosum. Does COVID affected these cases with pyoderma gangrenosum? It is mentioned that COVID-19 patients may also be at increased risk for developing pyoderma gangrenosum, and there are some cases reporting during the COVID period. Comorbidities, as I mentioned to you, here there are some of my cases with pyoderma gangrenosum and ulcerative colitis. Pyoderma gangrenosum, part of PASH syndrome, pyoderma, acne, and hidradenitis suppurativa, treated successfully with adalimumab, anti-TNF-alpha, and PAPA syndrome, pyoderma gangrenosum, pyogenic arthritis, and acne. Algorithm of treatment of pyoderma gangrenosum. This chart is quite important for everyday use, so we can treat pyoderma gangrenosum depending either in the severity of the case, but keep in mind that starting with high doses of corticosteroid or immunosuppressor, followed the treatment by biologics, it is a treatment of choice of pyoderma gangrenosum. How is the prognosis of pyoderma gangrenosum patients? The disease, to be sincerely, is unpredictable, has unpredictable course. It could be acute, and there are chronic forms, sometimes spontaneous healing, but as a lesion begins to disappear, new lesions sometimes may appear. Factors that lead to poor prognosis is age of the patient, ulcerative variants, they are hard to treat, concomitant systemic diseases, and of course other diseases, high CRP levels, clinical signs of wound infection sometimes affect the prognosis. And keep in mind that always it will be a cerebriform scar when pyoderma gangrenosum is treated. These are some cases treated, and you can notice the cerebriform scar in these cases treated correctly of pyoderma gangrenosum. These are again cases treated of pyoderma gangrenosum, the first case with malignant pyoderma gangrenosum on the face. You can see the improvement, but either you can see the steroid phase on the last photo. You can see the side effect of corticosteroid with high doses at that period, but I follow the treatment of my patients with anti-TNF-alpha. And as a conclusion, when you treat a patient with pyoderma gangrenosum, you have to think deeper than the skin. Pyoderma gangrenosum is a neutrophilic dermatosis, is a rare disease, but we have the chance to diagnose it mostly. It's part of orphan system. Actually, if we think for pyoderma gangrenosum, we have to think always for comorbidities that play a role in the prognosis in the course of the disease. Local and systemic treatment, of course, keep in mind immunosuppressor and biologic treatment. And this is my country where I'm coming from, Albania. And of course, we are learning together, growing together, and getting all together. Thank you very much, everybody in the room. Thank you.
Thank you so much. We had a beautiful symposium. We have some time for questions. So, any interaction? We have some questions from the electronic audience. This is one for, I think it's one for Acne. Dr. Wisit Srisanit asked about, do you have experience of treating acne, severe acne with only single therapy with 1726 nanometers? I think it's for Dr. Nugdis.
So yes, I do. Actually, we also did a study last year with the 1726 nanometer laser. There are actually two different lasers at the moment, so I'm not going to mention the name, but both work perfectly. So if you use it for moderate to severe acne, the results are better just if you do it for mild acne, because with mild acne or those like comedones, it doesn't work as good as inflamed acne. So actually, we know that acne is not something that you could completely cure, but the flare-ups and everything actually decreases, and it's better with 1 year until 1 year follow-up at the moment. Yes.
Thank you. Another question? We have another one from the audience on the internet. How much doses of isotretinoin do you use? I think it's in HS or acne, or, well, in HS only if it's a follicular pattern, and I use usually 10 to 20 milligrams per day. This is low doses, low to medium dosage. And in acne, maybe?
I saw during the presentation of Dr. Ophir that it was low doses of isotretinoin. So it means it would be around 10 milligram of isotretinoin, followed by the treatment with radiofrequence.
Any other questions or comments? It was a wonderful symposium. Thank you so much to the speakers, and thank you to the audience. Thank you.